Hello everyone, I'm Dr. Shariful Halid, and today I'm going to talk about some disorders of parathyroid hormone. So before going to the pathology, let's just review some physiology of parathyroid hormone. So it is obviously released from parathyroid gland, specifically chief cells of parathyroid, and the major function of parathyroid hormone is to ultimately increase the serum calcium and reduce the serum phosphate. And parathyroid hormone does that by increasing bone resorption of calcium, increasing reabsorption of calcium from kidney, and decreased reabsorption of phosphate in proximal convoluted tubule, which will ultimately lead to decreased phosphate excretion and hypophosphatemia. And parathyroid hormone also increases production of calcitriol or active form of vitamin D by stimulating the ultimate enzyme, which is 1-alpha hydroxylase, present in the proximal convoluted tubule of kidney. So by these, it also increases reabsorption of calcium in the gut. So the net effect of parathyroid hormone is increase in serum calcium and a decrease in serum phosphate. And the way it decreases serum phosphate is it increases the excretion of urinary phosphate. And so parathyroid hormone is also known as phosphate trashing hormone. And the main effect of parathyroid hormone is on the bones, and the way the parathyroid hormone acts on bones is like that. The parathyroid hormone, it increases the macrophage colony stimulating factor, and also it increases the expression or increases the secretion of rank ligand by osteoblasts and osteocytes. This rank ligand will ultimately activate the nuclear factor kappa B in the osteoclasts, and it will activate the osteoclasts. And whenever the osteoclasts are activated, it will cause an increased resorption of bone, and the bone will lose calcium, which will ultimately lead to increased calcium in the blood. And intermittent parathyroid hormone release actually stimulates bone formation, which is normal. So parathyroid hormone is regulated by multiple factors. One is calcium, another is phosphate, and another is magnesium. So whenever someone has a decreased serum calcium or hypocalcemia, it stimulates the secretion of parathyroid, which would ultimately correct the calcium problem. Whenever someone has an increased serum phosphate, it will stimulate the secretion of parathyroid hormone, which will ultimately correct the phosphate level and reduce it to a normal level. And in case of magnesium, it has actually two effects. Whenever someone has a mild to moderate decrease in magnesium, it will lead to increased parathyroid hormone secretion. But if the magnesium is severely decreased, it will lead to a decreased parathyroid hormone secretion, which is actually paradoxical. And decreased serum magnesium can occur in diarrhea, aminoglycoside therapy, in treatment with diuretics, and also in case of alcohol abuse. So let's first talk about the hyperparathyroidisms first, and the first one is called primary hyperparathyroidism. This occurs due to excessive secretion of parathyroid hormone from parathyroid gland, and it can occur in case of adenoma or hyperplasia. And as the main action of parathyroid hormone on the blood is to raise serum calcium, there will be hypercalcemia. There will be increased excretion of phosphate through the kidney, so there will be hypophosphatemia, and there will be it is called phosphaturic effect of parathyroid hormone, so more in urinary phosphate. And something there is different. As the serum calcium level is high, there will also be increased urinary calcium because increased filter load of calcium, which occurs due to action of parathyroid hormone on the bones, and also increased activity of the vitamin D on the intestines, raising the serum calcium level and raising the filter load. Ultimately, there will be a bit more excretion of calcium through the urine, but ultimately it will not affect the hypercalcemia because it will persist as hypercalcemia. And also there will be increased urinary cyclic AMP, which is actually due to action of parathyroid hormone on the tubules. And also, as I have already mentioned, it increases bone resorption, leading to increase in alkaline phosphatase. So the clinical features may vary from mild to asymptomatic to severe. So there can be a mild asymptomatic hypercalcemia, or there can be features of hypercalcemia. So whenever you have an excess calcium in your blood, it starts to deposit in different organs. It deposits in your kidney, deposits in your brain, in your intestines, causing many problems. So it can commonly it forms the stones, calcium oxalate stones, which is called nephrolithiasis. It can deposit in the renal tubules, potentially causing renal insufficiency and polyuria. It can deposit in the brain, causing depressions and maybe seizures. It can cause constipation, peptic ulcer disease, and acute pancreatitis. And as the bones are resorbed, there will be something called Osteitis, fibrosa, cystica. And here the resorption of bone leads to formation of cystic spaces and also fibrosis. So Osteitis fibrosis cystica is specific for primary hyperparathyroidism, where the cystic bone spaces which actually happen due to resorption are filled with brown fibrous tissue. And this brown fibrous tissue or brown tumor consists of deposited hemocysteine from hemorrhages, and it causes bone pain. Here you can see some cystic lesions in a patient's bone who happens to have primary hyperparathyroidism. So here it's another histologic picture. You can see renal papilla, and you can see some calcification which is in between tubules. It can possibly lead to renal failure and polyuria. So now comes the secondary hyperparathyroidism. Secondary hyperparathyroidism occurs in situations where there is no problem in the parathyroid gland, rather there is problem with calcium. Maybe due to some reason serum calcium level is low, which actually stimulates the secretion of parathyroid hormone from the parathyroid gland. And one most common and clinically important disease is chronic renal failure. And whenever someone has a chronic renal failure, the decreased GFR will lead to increased serum phosphate due to retention. And increased serum phosphate will complex to the calcium and lead to decrease in ionized calcium. So the decrease in ionized calcium will lead to stimulation of the parathyroid gland and secondary hyperparathyroidism. And also, as the patient has a renal failure, the kidney is damaged. The kidney cannot actually produce the sufficient amount of vitamin D, and as the vitamin D is reduced, it will also cause a reduction in calcium level. So you see, the hypocalcemia that occurs in chronic renal failure occurs by different mechanisms. First, you have a buildup of phosphate which binds calcium and reduces its level. You have a decreased synthesis of vitamin D, which actually reduces calcium, because vitamin D is responsible for calcium absorption from the intestines, calcium reabsorption from the bones, and that's why you have hypocalcemia. And this hypocalcemia leads to increased secretion of parathyroid hormone from the parathyroid gland. But though there is increased secretion of parathyroid hormones, this increased secretion cannot actually raise the calcium level up to normal level. So despite raised parathyroid hormone, hypocalcemia persists. And the decreased amount of active vitamin D and increased parathyroid hormone has detrimental effect on bones, which is called renal osteodystrophy, where there is increased bone resorption and osteomalacia. Tertiary hyperparathyroidism is a condition which occurs in severe cases where there is refractory hyperparathyroidism resulting from CRF or chronic renal disease. And here there is very high PTH, which results in increased serum calcium level. And another case of hypercalcemia which can occur in case of malignancy is due to secretion of something like parathyroid hormone but not parathyroid hormone. This is called parathyroid hormone related peptide, or PTHRP. It can occur in patients with breast cancer or lung cancer. Parathyroid hormone related peptide has the same kind of actions like the PTH, so it will increase the bone resorption, leading to increased calcium reabsorption, leading to increased calcium in the blood, also increased calcium reabsorption from the kidney and also indirectly from the intestines, and decreased renal phosphate reabsorption. So ultimately, it will be characterized by the findings which are commonly found in the primary hyperparathyroidism, such as increased serum calcium, decreased serum phosphate, and importantly, which is the main difference between primary hyperparathyroidism, is a decrease in serum parathyroid hormone levels, because feedback inhibition of high serum calcium will lead to decreased serum parathyroid hormone. This is the basic difference between hypercalcemia of malignancy due to PTH related peptide and hypercalcemia due to primary hyperparathyroidism. So the main determinant will be parathyroid hormone itself. So now let's talk about the hypoparathyroidism. The most common cause of hypoparathyroidism in the world is thyroid surgery, where there can be inadvertent removal of the parathyroid glands, which are actually situated behind the thyroid gland. And hypoparathyroidism can also occur due to autoimmune destruction or congenital absence of parathyroid glands in cases like DiGeorge syndrome. So whenever someone has hypoparathyroidism, the parathyroid hormones can no longer raise the blood calcium level, so there will be hypocalcemia. And hypocalcemia can manifest as numbness and tingling, especially circumoral numbness and tingling. And it can also lead to muscle spasm. And if hypocalcemia is mild to moderate, the muscle spasms can be elicited by shovel stick sign, and we actually demonstrated by tapping on the facial nerve, which causes contraction of the facial muscle. So shovel stick, tap on the cheek. Tertiary sign is another sign to see or to look for latent hypocalcemia, where occlusion of the brachial artery or BP cuff or cuffing the triceps will lead to carpal spasm. So those are the signs which need to be elicited in a patient who have a mild to moderate hypocalcemia. But if someone has severe hypocalcemia, he or she will develop tetany or spasms all over the body, and it can lead to possible death due to spasm of the laryngeal muscles. And hypoparathyroidism will lead to increase in serum phosphate or hyperphosphatemia due to a decrease in urinary phosphate excretion. And there is some condition called pseudohypoparathyroidism, where the parathyroid hormone level is normal, but there is resistance of the action of the parathyroid hormone on the target organs, especially in the kidney and the bone. It occurs due to a defective G-stimulatory protein. And as there is defective action of the parathyroid hormone or decreased action of parathyroid hormone, there will be features like hypoparathyroidism, like there will be hypocalcemia and there will be hyperphosphatemia. But the main difference is this hypocalcemia and hyperphosphatemia is not corrected by the administration of the exogenous parathyroid hormone, and the circulating parathyroid hormone levels are elevated. And there are some typical classic clinical features, like there will be shortened fourth or fifth metacarpal bones and also short stature. And this condition is autosomal dominant, and it's also known as Albright's hereditary osteodystrophy type 1A, pseudohypoparathyroidism type 1A. Here we can see a patient with a shortened fourth and fifth metacarpal, leading to shortened fourth and fifth finger in both hands. And there is another condition known as familial hypocalciuric hypercalcemia. This occurs due to defective calcium receptor on parathyroid cells. So parathyroid hormone cannot be suppressed by an increase in calcium, so there will be increased parathyroid hormone level, which will lead to increased calcium, and it causes mild hypercalcemia. So here you can see a summary of parathyroid hormone and calcium pathology. So this is very important. This is the most important slide of this lecture, and this picture can be subdivided into two parts. So the problems can either arise from parathyroid gland itself, or there can be problem with calcium itself. So let's first talk about the parathyroid hormone problem. So the parathyroid gland can either hypersecrete parathyroid hormone or hyposecrete parathyroid. So whenever there is excessive secretion of the parathyroid hormone, there will be increase in parathyroid hormone level like this, and this increase in parathyroid hormone level will act on the calcium and increase the serum calcium level. So here you can see in this box, which shows a primary hyperparathyroidism, there will be increase in parathyroid hormone level, which will lead to increase in calcium level. So shift of the structure to that, the rightward and upward shift occurs in primary hyperparathyroidism, and a downward and leftward shift can occur in hypoparathyroidism. So again the problem starts with the parathyroid hormone itself. So due to some reasons, parathyroid hormones cannot be secreted, so the parathyroid hormone level is down, and as parathyroid hormone level is down, the calcium level in blood also falls, so calcium level falls. So this leads to hypoparathyroidism, and where parathyroid hormone level are low and calcium level are low. So you see the primary problems with parathyroid gland itself. Now some cases the problems can start with calcium. So for some reasons your calcium may be high. So suppose your parathyroid gland is absolutely normal, but your calcium level are high. So this high calcium level will have a negative impact on the parathyroid hormone secretion. So you have a high calcium level which will inhibit the secretion of parathyroid hormone. So there will be a decrease in parathyroid hormone secretion, which actually is shown here. So primary increase in calcium, which leads to decrease in parathyroid. And for some reasons your calcium may be low. So suppose your parathyroid gland is absolutely normal, but you have a decrease in calcium. So whenever you have a decrease in calcium, it will stimulate the parathyroid gland to release increased amount of parathyroid hormone. So you have a primary disturbance in hypocalcemia, which stimulates the parathyroid hormone, and the parathyroid hormone level are high. So in this box it shows that parathyroid hormone levels are high due to a low level of calcium. So this is kind of a busy slide. Let me summarize it again. So whenever you have problems with primary problems with parathyroid, there will be primary hyperparathyroidism where both of the parathyroid hormone and calcium are high, or if you have problems with parathyroid like decreased synthesis of parathyroid hormone, which is hypoparathyroidism, there will be decrease in both of parathyroid and calcium. So in case of parathyroid disorders, calcium and parathyroid go up or down together, they are together. But in case of disorders which starts with calcium, they actually go in opposite directions. So if the disorder starts with calcium, the parathyroid hormone level will be up or low in the opposite direction. Suppose you have hypercalcemia, parathyroid hormone levels down. Suppose you have hypocalcemia due to some reason, parathyroid hormone levels will be up. So that's all from me. Thanks all for watching my video.